Greetings. Thank you to the organizers for inviting me here to discuss unmet needs in amyloidosis diagnosis and care. Why are more specialist centers required? I am Vaishali Sanchorawala from Boston University Amyloidosis Center in Boston, Massachusetts. These are my disclosures. Outline of my talk in unmet needs in amyloidosis will focus on patient journey, health disparities, and access to care. Amyloidosis remains a rare disease. Specifically, AL amyloidosis has an incidence of 1.2 cases per 100,000 person years, and hence the path to diagnosis can be quite complex and rocky for our patients. Amyloidosis Research Consortium, a patient-led organization, performed a social media survey of approximately 500 patients with amyloidosis and noted that time from initial symptoms to diagnosis of amyloidosis can be greater than 12 months in 40% of the patients. Moreover, number of physician visits before establishment of diagnosis can be greater than 2 for over 60% of the patients. And shockingly, these patients were diagnosed by primary care physicians only in 4% of the cases. Primary care physicians are supposed to be the gatekeepers of healthcare systems. So this survey indicates significant delays and multiple physician visits before a diagnosis of amyloidosis is obtained. What is different in 2022? Amyloidosis Research Consortium again performed a community survey of more than 1,200 patients and caregivers across the globe who participated in this survey. And the results were still quite shocking. Average physicians seen before accurate diagnosis of amyloidosis was obtained were 2 to 3. And top 3 barriers to diagnose amyloidosis were misdiagnosis, trouble getting tested, and reported trouble finding a specialist. The French study, including 603 patients, also suggested that the average time from symptom onset to diagnosis is 27 months. For patients with AL amyloidosis, it's 21 months. And for patients with hereditary ATTR amyloidosis with peripheral neuropathy, it is close to 4 years, 45.6 months. So the path to diagnosis of amyloidosis across the globe remains quite complex and long. Now, moving on to health disparities. This is a large Boston University amyloidosis center study of 2,400 patients with AL amyloidosis over 30 years, showing the racial and ethnic composition. In this cohort, minorities comprised of only 14% of the entire cohort, and majority of the patients were non-Hispanic whites. Moreover, non-Hispanic Blacks and Hispanics were younger and with more advanced stage of disease. Moreover, disparities in stem cell utilization, a standard of care treatment for AL amyloidosis, were driven by both socio-demographic and physiologic factors rather than race and ethnicity itself. Race and ethnicity did not have an independent effect on survival after controlling for disease severity and treatment use. Similar data from our center at Boston University, which is an unpublished data of ATTR amyloidosis of 1,000 patients over 50 years, showing the racial ethnic composition of this cohort, showing that the minorities comprised of 20% of the cohort, and majority of these patients were again non-Hispanic whites. 57% of patients received more than one treatment for ATTR amyloidosis. However, only 44% of non-Hispanic Blacks received treatment for ATTR amyloidosis. TTR stabilizers and TTR silencers were received by 33% of non-Hispanic Blacks compared to 44% of non-Hispanic whites. Access to care is the next topic on this outline of my presentation. This is a study from Boston University Amyloidosis Center with regard to patient outcomes in AL amyloidosis. The clock is ticking from symptoms to diagnosis. The median time from symptoms to diagnosis in this cohort was 7 months, ranging from 1 month to 61 months. The median follow-up on this study was 61 months. And as shown in figure 1b, median time from symptoms to diagnosis was less than 6 months for those who survived at the time of median follow-up of 61 months. However, in contrast, median time from symptoms to diagnosis was greater than 6 months in 2/3 of the patients who did not survive at median follow-up of 61 months. In Kaplan-Meier survival curves, patients who were diagnosed within 6 months of symptom onset had better survival than those who were diagnosed for more than 6 months from symptom onset. This cohort study found that amyloidosis-related mortality reported from the US death certificates significantly increased from 1.7 to 3.9 per million from 1979 to 2015. The highest age-adjusted death rate for amyloidosis in the USA were in the Black men and Black women. However, the southern states of the United States reported the lowest mortality despite having highest proportions of Black residents in the southern states. What does this mean? Geographic and racial variations in reported amyloidosis death rates suggest the potential for regional and geographic underdiagnosis. Again, also, this refers to access to best care available for patients living in the southern states. Not all amyloidosis as it seems. The presence of a monoclonal protein does not guarantee a diagnosis of AL amyloidosis. Moreover, existence of one type of amyloidosis does not make one immune to other types of amyloidosis. It requires experience to connect the dots. In conclusions, there are several unmet needs in diagnosis and care of patients with amyloidosis, and these are listed on the slide. Prompt diagnosis is crucial to improve patient outcome. Bridging the educational gap to increase awareness of this rare disease remains an unmet need. There are limited specialist centers in many regions across the globe, and patients have to travel distances for assessments at specialized centers, posing challenges for older, lower income, and advanced disease patients. Lack of centers also restricts access to early diagnosis and appropriate treatments. Moreover, absence of multidisciplinary care models do exist in many centers, and scarcity of accessible clinical trials and stringent eligibility criteria for the clinical trials restrict access to state-of-the-art treatments. With that, I would like to acknowledge the many members of the basic science and clinical teams at Boston University Amyloidosis Center. So thank you for your attention. And now I will be handing over to Professor David Adams and Professor Laura Obici.